I mainly focus on IBD patients. However, I realized early on that Clostridium difficile infection is a very common infection and difficult to treat among IBD patients. So I started our fecal microbiota transplant program in May of 2012 at Indiana University. I realized that my patient population is going to be quite wider than just restricted to my IBD patients. So far we have successfully treated over 300 patients. Beyond the scope of treating patients with recurrent C-diff in an ambulatory setting, I realized that I can make a difference in patients who have severe C-diff and actually a condition which can be life-threatening. So I started to administer fecal transplant also in hospitalized, severely ill inpatients with C-diff, and we developed a protocol the last 2 years combining fecal transplant with antibiotics diets. Traditionally treat C-diff, but they might not be sufficient when the infection is so severe. So by administering repeated fecal transplant, we developed this sequential fecal microbiota transplant protocol in combination with vancomycin. With this, we saved over 40 patients to date, and they avoided colectomy, which is a really significant advancement, if you will, because in the setting of severe complicated C-diff, the colectomy is associated with 50 to 80% mortality within 30 days. And with our approach, just using fecal transplant and continued vancomycin, we helped to about 90% of the patients to avoid surgery. One presentation is a collaborative study between Indiana University and Brown University. We aim to look into the clinical predictors of fecal transplant failure. Cumulative evidence suggests that fecal transplant is highly successful in the treatment of recurrent C-diff. However, we know that 10 to 20% of patients fail. Today it is not known what their risk factors associated with the failure. With Colleen Kelly at Brown University and myself, included a total of 358 patients into an analysis, and what we found was that first of all, the overall failure rate was somewhat higher than what was published previously in randomized controlled trials or case series, and I think it probably reflects a real life setting over. So our overall failure rate was 23%, but I must emphasize that we have a large portion of patients who had severe disease, were inpatients, and also immunosuppressed. And what we found in the study, in the multivariable regression analysis, that being an inpatient at the time of the fecal transplant increased the risk of failure by 7-fold. Immunosuppression increased the risk of failure by 3.5-fold. And having history of C-diff related hospitalization increased the risk by 45% with each hospitalization. So we found that actually variables pre-transplant can be used to predict the risk of failure. Based upon our final predictors, as I mentioned, inpatient status at the time of fecal transplant, immunosuppression,